these patients. Next up, we'll have Dr. Rajiv while he connects to his presentation. I'll give you a brief introduction. He's a senior consultant at Shankar Nethralaya, Chennai. He also works very closely with the Department of Medical Science and Technology, IIT Chennai. He's finished his training in retina after his MS and DNB from Shankar Nethralaya itself, and he's been there since then. He's also finished his FRCS, and he's done a lot of community work, based on retinal changes such as diabetic retinopathy. So I think he's the best person to tell us about imaging, especially for retinal vascular diseases. Over to you, Rajiv.
Thanks, and thanks Optos for organizing this session. Next 8 minutes, I'll be talking on the ultrawide field imaging in retinal vascular diseases. And I'll be mainly concentrating on diabetic retinopathy and retinal vein occlusion. So as we have seen in the previous, Chaitra has told us that definitely the more area of the retina you see, you can identify more lesions. And in diabetic retinopathy, 10% cases, the severity scale of diabetic retinopathy will change if you consider these peripheral lesions alone also. And this was one of the work which we had done with Dr. Sadda and all the institutes. We have Chaitra here, where we tried looking at that. We knew that a third lesions are PPL. We knew the numbers from the Western data. We never knew what happens in Indian population. Even in India, a third of diabetic retinopathy has PPL, the predominantly peripheral lesions. And we also found that mainly it's in the temporal quadrants. We had this very good paper which came out by Dr. Lord Paul Ailolo group, which suggested at that time that if you have this presence of predominantly peripheral lesions, these are the lesions which these patients have 4 times more risk of progression to proliferative disease. And definitely everybody was keen, and there was more use of these peripheral lesions identification using wide field cameras. We tried comparing whether you need a more resolution or you need a wider view, and we compared 2 of the wide field cameras and tried looking at the quality of the image to identify the posterior lesions versus peripheral lesions. And what we found that yes, both are equally important as far as diabetic retinopathy is concerned, and Optos, which was one of the camera which we had used, definitely overscores looking at these peripheral lesions. We also wanted this was another work that as a clinician, we don't always have grading center or reading center who grades these images. What happens among the clinicians, so we had senior retina specialists grading these images, and we found for diabetic retinopathy, early diseases, early stage of the disease, mild and moderate, about 15% cases, there is a disagreement as far as grading diabetic retinopathy is concerned whenever you use a wide field image. And traditionally, we also knew from long time that in ocular ischemic syndrome, we have these peripheral hemorrhages, mid-peripheral and peripheral hemorrhages. So is there any correlation of these peripheral hemorrhages with systemic disease? This was a work which we had done with Dr. Giridhar, and we tried looking at can we correlate with systemic features these PPL lesions, and we did find that those who had peripheral hemorrhages in diabetic retinopathy, they had more prevalence of coronary artery disease. And this is again a work with Dr. Sadda. We had these images, wide field images. We tried correlating, is it correlating anyway from the posterior pole ischemia? And the answer was no. So the eyes with PPL, they didn't have worse macular perfusion. This was presented in ARVO, and soon I think we'll be seeing this in publication too. And definitely we use Optos to precisely target panretinal photocoagulation if you are having targeted PRP. And many times we want to assess the adequacy of panretinal photocoagulation to assess which areas you want to cover more, do more fill-in. Optos definitely is a ready tool. And then this paper came up, the DRCR-NET protocol AA, where they found that the worsening was not related to the color fundus peripheral lesion, but with the fundus fluorescein angiogram, PPL. And they had 1.7-fold times more risk of disease worsening in 4 years. And they said that fundus photography cannot be replaced because 36% cases, there was a difference in grading between the fundus photo and the fluorescein angiogram predominantly peripheral lesion, and it was a non-perfusion area which was important lesion as far as FAPPLs were concerned in diabetic retinopathy. We also tried looking at our data set to see that how many of these lesions are beyond 7 field. A very quick study, about 61 eyes we looked, and we also found a similar thing. There are nearly equal lesions on fundus fluorescein angiogram on 7 field versus the wide field, predominantly peripheral lesion, and CNP areas being the most important lesion. That makes sense now to quantify these ischemic thing, and probably measuring ischemic index would be one way, which is adding the surface area of non-perfused area, dividing it with surface area of the total fundus, multiplying by 100. And there are studies which have shown it correlates with severity, the progression, risk of neovascularization, treatment response, and even there are studies showing that it correlates with visual prognosis. It's difficult and very erratic, and the problem have been that it's difficult to reproduce in clinical practice, especially because in diabetic retinopathy you have these patchy non-perfusion. And if you look at reproducibility across various diseases, the least is in branched retinal veil occlusion, where we know there's a definitive segment which is ischemia, intermediate in CRVO, and the most variations occur in diabetic retinopathy. You can see these patchy areas of ischemia. Definitely the chances of reproducibility between the same patient will be less. Is there any better way we can measure these non-perfusion areas? People have used grids, and the grids were a problem because these grids, especially, there was a problem of peripheral warping. However, the newer Optos machines, California has got a ProView which compensates for this peripheral warping. You don't need to use additional software, and you can use these grids to measure the area of non-perfusion. I'll end with one of the marker which we have the person who has described this, Dr. Sadda here, who described this novel biomarker of RVBA, the retinal vascular bed area. Again, one of the marker which you can identify on a wide field angiogram. It represents the total surface area of arteries and veins. It's an indicator of angiogenesis but not non-perfusion, and it delineates the larger and medium caliber vessels. And there were studies which showed correlation of RVBA with a more severity of retinopathy. Higher RVBA was associated with proliferative disease. Also, there were studies which Dr. Sadda led to identify what happens after anti-VEGF, and there was reduction in RVBA in PDR which were treated with anti-VEGF either monthly or 3 monthly, and monthly injection had more reduction in RVBA, again suggesting that probably RVBA could be a novel biomarker to monitor the changes, to look at the efficacy of retinal vascular changes after anti-VEGF if you are planning to use it in proliferative diabetic retinopathy. I'll share some of the examples. We had already seen a lot of these examples where no Optos or California shows importance, and this you have proliferative diabetic retinopathy. Do a wide field, you can see how extensive the disease has been. This was a very interesting kid who came with this type of exudation. Just last slide. And this was the other eye. Looks more like, the first thought was probably we are dealing with FEVR. You zoom in, you can see this bicycle wheel pattern in the macula. We did a ERG. It was more of a retinoschisis, and there are reports describing severe Coates-like response even in retinoschisis. And when I looked at his brother, who also had decreased vision, and how beautifully you can see with this angiogram that this is not a FEVR case. Clinically, the moment I looked, it looked like we are dealing with a FEVR. On Optos, an angiogram, we could definitely delineate. This is the other eye. Thank you very much.
Thank you, Rajiv. Fantastic talk. Can I request Dr. Vatsal to connect? And in the meanwhile, Dr. Sadda, would you have some more insights into this? Because a lot of this work, you have really initiated. Yeah. So if you could just, because I think your topic doesn't really touch on this. So if you would like to tell us certain new insights.
First of all, I think Dr. Rajiv gave a great talk, really great overview of what we've learned about the importance of these peripheral findings, right? That they have prognostic value in various diseases. I think Dr. Rajiv really spoke, I think, beautifully about in diabetic retinopathy, these peripheral lesions, these areas of peripheral non-perfusion. They make a big difference. I mean, the fact that for so many decades we've been staging the disease using mainly the posterior pole or the 7 standard field really highlights what we've been missing. So I think it was really an excellent presentation.
Yes, I remember though that this work has been ongoing since I think over a decade. And when I went and worked with him I think 10 years back, I remember sitting and annotating each of those peripheral lesions, in early diabetics. And we've actually managed to even create a model which predicts whether this disease has progressed or not. I think there's some fantastic work going on with Whitefield.